Hi everyone, my name is Emma Mathern, and today we will be talking about pediatric traumatic brain injury. Our learning objectives for today are to review the types of traumatic brain injury, discuss the changes that occur in the cranial cavity in response to injury, to understand intracranial pressure and methods for monitoring, as well as to discuss methods for management of TBI, including hyperosmolar therapy, intubation, vasopressors, and seizure prophylaxis. Traumatic brain injury is the leading cause of death and disability for children and young adults, with an incidence of about 475,000 pediatric patients sustaining a TBI per year. And traumatic brain injury is the leading cause of hemorrhage in older children and adolescent patients. There are differences in the pediatric brain that can cause them to be more susceptible to adverse effects from traumatic brain injury. These changes include thinner skin and subcutaneous fat layer, which gives them less protection against external forces. As well as the bones of their skulls have sutures that are more mobile and can move more in response to stress than in the adult brain. Younger patients also have less dense brain matter due to less myelination, which increases their susceptibility to traumatic brain injury. There are two types of injury in traumatic brain injury. The first is the primary injury, and this occurs at the time of impact. It can result in an altered level of consciousness. Secondary injury is what occurs after primary injury, and the role of healthcare providers is to try and prevent this. And secondary injury results from hypoxia, ischemia, hypotension, hematoma, and hypertension, as well as seizures and fever from the primary injury. There are principles of the cranial cavity that help us better understand why there are so many consequences of TBI. The first is the Monroe-Kelly doctrine that says that the cranial cavity is a fixed volume. And with this fixed volume, if there's an increase in one of the components, then another component must be lost. And as you can see here in the diagram on the right, the three compartments of the brain are cerebral spinal fluid, blood, and the brain. So if there's brain swelling due to traumatic brain injury, then that would result in an increase in the brain matter portion of the cranial cavity, which would then cause other components to have to decrease. And so that's when our therapies come into play. Cerebral edema is swelling of the brain, and this can occur in response to traumatic brain injury. It is considered to be symptomatic, typically at an ICP greater than 20 millimeters mercury, and can result in altered mental status, seizures, coma, and death. The causes of this, like we are talking about today, is TBI, but it can also be caused by CNS infection, ischemia, and hemorrhage. The consequences of cerebral edema include herniation and midline shift, which we want to prevent due to the fact that these can be fatal if untreated and unnoticed. In addition to the pharmacologic therapy that we will go over, there is non-pharm therapy that we want to make sure we are providing for our patient. The first is to elevate the head of the bed to 30%, as well as keep the head and neck in a neutral position. And then if they have a neck brace, ensuring that that's not overly tight. For monitoring of traumatic brain injury patients, we will look at Glasgow Coma Scale, which indicates the patient's level of neurologic function, and their ability to protect their airway. The GCS is categorized into 3 categories, and the higher the GCS, the better the patient's neurologic function. A GCS of 13 to 15 is considered mild injury. 9 to 12 is moderate injury, with 3 to 8 being severe injury. And that would be a patient in that category would be considered unable to protect their airway, and we would think about intubation for those patients. We can also utilize invasive intracranial pressure monitoring, especially for those patients with a GCS of less than 8 or severe injury. This is done with an external ventricular drain, which can also help us by draining off excess cerebrospinal fluid. This is also called a bolt, and when it's in place, it's recommended to prophylax with cefazolin at surgical prophylaxis dosing. We also need to monitor these patients for coagulopathy and correct as required due to the risk of hemorrhage, and monitor for any other medications that may increase their risk of bleeding. We will also use this to monitor ICP and cerebral perfusion pressure. There are thresholds for treatment that we think about. For ICP, the threshold is anything less than 20 millimeters mercury for greater than 5 minutes. Transient increases of this do not require treatment. However, if the ICP is greater than the patient's MAP, then that indicates an inability to perfuse their brain. Cerebral perfusion pressure is the arterial pressure minus the intracranial pressure. Normal is 40 to 50. However, for infants, the lower end of the range is considered normal. And so if the CPP is too low, then that would indicate the need for treatment. In patients with traumatic brain injury, we can also monitor for the Cushing's triad, which is typically kind of what we can see in response to traumatic brain injury. So these include bradycardia, wide pulse pressure, and irregular respirations. So when a patient is displaying these types of symptoms, it's important to be ready to utilize pharmacologic treatment and be ready to intubate the patient as needed. Now we'll get into pharmacologic treatment, and we'll go through each of these categories one by one. So we'll go over hyperosmolar therapy, analgesics, sedatives, and paralytics for intubation, vasopressors, seizure prophylaxis, EVDs, hyperventilation, hypothermia, and surgical intervention. Hyperosmolar therapy utilizes the higher osmolarity of pharmacologic agents in order to help pull fluid off of the brain. The 2 most common agents are mannitol, which has an osmolarity of 1,100 milliosmoles per liter, as well as hypertonic saline, which has the osmolarity of 1,027 milliosmoles per liter. These are both greater than the osmolarity of CSF, which has an osmolarity of about 290 milliosmoles per liter. To better explain the mechanism of action of hyperosmolar therapy, I wanted to use this image. As we all know from early chemistry courses, when there's a membrane in between 2 fluids, with one having more solute particles than the other side of the membrane, the side of the membrane with a higher osmolarity will pull fluid from the other side of the membrane in order to achieve an equiosmolar gradient. So by giving these agents intravenously, the blood will have a higher osmolarity than the brain, which will cause the body to push fluid from the brain into the blood to decrease the osmolarity of the blood, which can help with cerebral edema by pulling that fluid off. As I mentioned earlier, the two main hyperosmolar agents used for this indication are mannitol and hypertonic saline. There's a lot of debate about which of these agents is preferred, so I just wanted to provide a summary of the literature that I found comparing these two agents. In some studies, hypertonic saline did result in a larger decrease in ICP when compared to mannitol, and patients who received hypertonic saline had a higher GCS following therapy. Many patients who received mannitol initially ended up receiving hypertonic saline as a second-line therapy in order to better decrease intracranial pressure. And most studies point out that mannitol is understudied and that larger trials are needed to really best compare mannitol to hypertonic saline. The last consideration between these two agents is really which is safer for peripheral infusion, because these traumatic brain injury patients are typically going to be coming into the emergency department without IV access, and so a PIV will need to be placed in order to administer medications. So there is a retrospective cohort study from 2019 that looked at the safety of peripheral infusion and compared the use of mannitol and hypertonic in adult patients as well as pediatric patients who received either hypertonic or mannitol via peripheral infusion. The indications included in this study were traumatic brain injury, acute ischemic event, or intracranial hemorrhage. They did exclude any patient who received both agents via the same PIV, as well as pregnant patients and any patient who didn't actually have the medication administered. Dosing strategies included 5 mL per kilogram bolus for hypertonic saline and 1 gram per kilogram bolus for mannitol. This study found that neither agent was associated with extravasation when given via peripheral infusion. They also found that hypertonic saline had a greater decrease in ICP at 24 hours, as well as a higher GCS when compared to mannitol. They also found that hypertonic saline had a shorter duration of days of mechanical ventilation needed, as well as lower in-hospital mortality. The dosing for hypertonic saline is 2 to 5 milliliters per kilogram with a max of 500 milliliters given over 10 to 20 minutes. It is typically administered over about 15 minutes. Adverse effects include hypernatremia and hyperchloremia. Mannitol is dosed at 0.5 to 1 grams per kilogram with a max of 2 grams per kilogram given over 20 minutes, and it is typically given over 20 to 30 minutes. Adverse effects include rebound cerebral edema through the accumulation of mannitol in the brain, and it is important to remember that this medication will crystallize at low temperatures, and so that needs to be assessed prior to administration. Now we're getting into intubation, and there are a few key concepts to remember. Patients should always be pre-oxygenated prior to attempting intubation, and we want to optimize first pass success for these patients with traumatic brain injury. So it's important to have the most experienced provider attempting intubation, as well as having the appropriate equipment and personnel available. It's also important to remember that we will pre-medicate these patients, but we do have to provide post-intubation sedation on top of our pre-medications. For intubation, we want to make sure that we are pre-medicating to provide analgesia, and one of the medications we can use to do this is fentanyl at a dose of 1 to 5 micrograms per kilogram. Of note, if given undiluted, fentanyl can cause chest wall rigidity. Other medications that we can give prior to intubation include atropine, and this is used to prevent bradycardia due to vagal nerve stimulation. Other pre-medications for intubation should provide retrograde amnesia in order to prevent the patient from remembering being intubated. And these agents all have different adverse effects and clinical pearls that should be considered and used to individualize therapy for patients. The first medication is propofol, which has an immediate onset, however can cause propofol-related infusion syndrome, as well as vein irritation and urine discoloration. The other thing to remember with propofol is that it does come in a glass vial, which needs vented tubing in order to be administered properly as a continuous fusion or as a bolus from the vial. One good thing about propofol is that it has a really quick on and off effect. So for patients who are going to need a neurological exam after intubation, the propofol has a quick off in order to provide an opportunity for that exam. Midazolam has an onset of 1 to 5 minutes, and with all of our benzos, we do worry about respiratory depression when used in combination with other CNS depressants. However, for a patient who we are trying to intubate, respiratory depression isn't so much of a worry. Midazolam is also a good agent for those patients who begin seizing and go into status epilepticus due to their traumatic brain injury. The next agent is etomidate, which has an onset of 30 to 60 seconds. Adverse effects include injection site pain, adrenal suppression, which can be overcome with steroids, and it can also decrease seizure threshold, so it may not be the best agent for patients who are at risk of seizures. Ketamine is the last agent we will go over for retrograde amnesia. This agent also has an immediate onset and can cause hypertension, and there's some thought that it can increase ICP. It can also cause emergent syndrome, which can be treated or prevented with benzodiazepines. And the last adverse effect of this medication is that it can aggravate right-sided heart failure. So for patients who we know have congenital heart defects or other comorbidities, this may not be the best option. The final medication needed for intubation is a paralytic, and paralytic should always be given after your sedation agents have been given. You should never be giving a paralytic without any sedation. The two paralytics typically used for intubation are rocuronium, which is typically given at a dose of 1 milligram per kilogram. It can cause a slight histamine release. However, this is the preferred agent for pediatric patients. In adults, sometimes they will use succinylcholine at a dose of 2 to 3 milligrams per kilogram. However, it has the adverse effect of hyperkalemia, which is a worry for pediatric patients, as well as any patient who has had a prolonged or unknown amount of downtime. As I mentioned earlier, we also need to remember to provide sedation to our patients post-intubation in order to keep them comfortable, as well as to help us keep them intubated. For pain, we can give fentanyl or morphine. Fentanyl can cause hypotension, bradycardia, and intracranial hypertension, however, and morphine can cause histamine release and CNS depression. For anxiolysis post-intubation, we can use midazolam, which is good for our patients who might have been seizing. However, it can have adverse effects on brain development in younger patients, so we want to avoid prolonged use of midazolam. Dexmedetomidine is also a good add-on agent. We just have to remember that it can decrease heart rate and blood pressure, especially at higher doses. Ketamine can also be used post-intubation, and it also has its own adverse effects to consider, like emergent syndrome, hypertension, tachycardia, and again may worsen right-sided heart failure. The guidelines recommend using vasopressors in order to avoid hypotension, and this is to ensure that we are maintaining mean arterial pressure and cerebral perfusion pressure. In terms of agents, we want to think about the level of vasoconstriction that we're wanting, with phenylephrine being the most potent vasoconstrictor, followed by norepinephrine, and then epinephrine and dopamine. If we're considering phenylephrine as the agent to be used, we need to remember that this is indicated for patients in neurogenic shock to preserve MAP and cerebral perfusion pressure, and we want to reserve this for patients who require aggressive preservation of neurologic function. For patients experiencing post-traumatic seizures, we can categorize these into 3 different stages. The first being immediate, which is seizures within the first 24 hours of injury. Early, which is 24 hours to 7 days after injury. And late, which is seizures occurring greater than 7 days after injury. For acute or ongoing seizures, the agents recommended to stop the seizure include things like Ativan, midazolam, Keppra, and valproic acid at higher doses. And following management of the acute injury, seizure prophylaxis is recommended for 7 days. And the go-to agent is typically Keppra at a dose of 10 milligrams per kilogram twice daily. For patients with refractory intracranial hypertension, we can also consider barbiturates. These patients should be monitored for cardiorespiratory instability, and some data shows that barbiturates can transiently cause hypotension, which would offset the benefit of its ICP lowering effects. External ventricular drains can be used to temporarily drain excess CSF from the brain through the use of gravity, and this is the method of choice for removal of excess CSF. We will provide patients with replacement of the drainage with normal saline on a 1-to-1 basis in order to prevent hypochloremic metabolic alkalosis. And then I don't have this on the slide, but some institutions will use cefazolin for infection prevention in these patients. However, generally antibiotic prophylaxis isn't recommended. Transient hyperventilation has also been evaluated for the treatment of traumatic brain injury. However, it is recommended to avoid this in the first 24 hours post-injury unless the patient is exhibiting signs of herniation like dilated or non-reactive pupils, the Cushing reflex, or posturing. Hyperventilation is recommended only for patients who are herniating because of its association with increased mortality when used early on in the injury process. If this is used, patients need to be monitored for ischemia. Hypothermia is another therapy that has been evaluated for TBI. However, it in studies did not change the risk of mortality, and it did increase the likelihood of good neurologic outcomes. If this is used, a goal temperature of 32 to 33 degrees Celsius is recommended. And if the patient is receiving phenytoin for seizures, then the dose of phenytoin will need to be adjusted during rewarming. Surgical interventions include decompressive craniotomy, which is indicated for patients with herniation due to refractory intracranial hypertension. Finally, I wanted to mention that the guidelines recommend against the use of steroids for treatment of traumatic brain injury because they did not show an improvement in outcomes neurologically or an improvement in ICP, and they actually increased the risk of death for these patients at 2 weeks. So the conclusions that we can draw from this presentation are that traumatic brain injury, it consists of primary and secondary injury, and the role of the healthcare team is to try and prevent the secondary injury. The cranial cavity is a fixed volume, and in response to injury or inflammation, that can lead to displacement of one of the 3 compartments. Monitoring in TBI patients includes the ICP and GCS, and management of traumatic brain injury includes agents like hyperosmolar therapy, intubation, vasopressors, seizure prophylaxis, among other therapies.